Welcome, candidates, to this high-yield explainer. Look, if you're gearing up for the MSRA, you already know respiratory failure is an absolutely massive, highly testable topic. Today, we're going to hack the exam and master the pathophysiology, diagnosis, and management of acute respiratory distress syndrome, or ARDS. I'll guide you through this, breaking down literally exactly what you need to know to dodge those traps the examiners just love to set.
Here's our roadmap for today. 1. Pathophysiology of ARDS. 2. The Berlin definition. 3. ARDS versus heart failure. 4. Management and exam traps. And 5. The 10 MSRA questions. Let's get right into it.
Section 1. Pathophysiology of ARDS, the broken barrier. When we talk about ARDS, the two absolute most important words you need to hammer into your brain are non-cardiogenic and inflammatory. ARDS is a severe form of non-cardiogenic pulmonary edema, and it results from a widespread inflammatory lung injury. It is so critical to understand that this is a structural failure driven by inflammation. Basically, a direct or indirect trigger sets off this massive inflammatory cascade, right? And that totally trashes the fragile barrier between the alveoli and the capillaries, literally flooding the lungs with protein-rich fluid. It's essentially a dual cellular hit, which is what makes RDS so incredibly deadly. First, you have type 1 pneumocyte damage. These are the super thin cells responsible for gas exchange. When they get destroyed, protein-rich fluid just pours in, hyaline membranes form, and you end up with refractory hypoxaemia, meaning the patient remains totally starved of oxygen no matter how much you crank up the flow. Then you've got type 2 pneumocyte damage. Now these cells normally pump out surfactant. Without it, the alveoli just collapse in on themselves, causing widespread microalectacies. So you lose gas exchange and the lungs collapse. That right there is the core mechanism of RDS.
Section 2. The Berlin definition. The rules of the game.
To formally diagnose ARDS, your patient has to meet all 4 of these strict Berlin criteria. First up, timing. The onset absolutely must be within 1 week of a known clinical insult or new respiratory symptoms. Second, chest imaging. You need to see bilateral opacities that can't just be explained away by something like effusions or nodules. Third, origin. The respiratory failure cannot be fully explained by heart failure or fluid overload. And finally, oxygenation impairment. This is measured by a falling PaO2 to FiO2 ratio while the patient is on PEEP. Section 3. ARDS versus heart failure, the great pretender. So here comes the most common trap on the exam, differentiating ARDS from cardiogenic pulmonary edema. The primary mechanism of ARDS is an inflammatory capillary leak, whereas heart failure is all about high hydrostatic pressure. Because of this, the pulmonary capillary wedge pressure, or PCWP, is normal or low in ARDS, but elevated in heart failure. Similarly, the BNP level will be normal or maybe just mildly elevated in ARDS, but sky-high in heart failure. If you do an echo, ARDS shows normal left ventricular function, while heart failure shows an abnormal ejection fraction. And crucially, the hypoxaemia in ARDS is refractory. It doesn't respond well to oxygen. A heart failure patient, on the other hand, will typically improve with oxygen and diuresis.
Section 4. Management and exam traps. Passing the MSRA.
The critical care strategy for ARDS is strictly protocol-driven. Step 1 is protective lung ventilation. You have to use low tidal volumes, specifically less than 6 milliliters per kilogram of ideal body weight. Why? Well, because you want to avoid blowing out those fragile, inflamed lungs, which is a concept known as volutrauma. Step 2 is prone positioning. This is recommended for moderate to severe cases to improve the matching of ventilation and perfusion. And step 3 is a conservative fluid strategy. You basically want to keep them relatively dry to minimize further alveolar leakage, obviously without compromising organ perfusion. Now, be warned. A staggering 27% of MSRA candidates fall for the PCWP trap. They see pulmonary edema in the clinical stem and immediately assume the pulmonary capillary wedge pressure has to be high. Please do not make this mistake. Remember, the core mechanism of ARDS is a low-pressure leak. The barrier is broken because of inflammation, not backed-up pressure from the heart. So, the pulmonary capillary wedge pressure in ARDS is normal. When you're reading a clinical stem, you need to spot the trigger super quickly. Anchor your memory to the Spartan mnemonic. Sepsis, pneumonia, or pancreatitis, aspiration of gastric contents, radiation or recurrent transfusions, trauma, amniotic fluid embolism, and near drowning. Spartan. But keep in mind, sepsis is the single most common trigger overall. If a question describes a patient with severe sepsis who suddenly develops bilateral infiltrates and oxygen levels that just won't rise, ARDS should be flashing in neon lights in your brain.
Section 5. The 10 MSRA questions. The gauntlet.
You've built the foundation. Now it is time to face the gauntlet with 10 mandatory practice questions that mimic exactly what you'll see on test day. Question 1. A patient develops acute respiratory failure 48 hours after severe acute pancreatitis. Which hemodynamic parameter differentiates ARDS from cardiogenic pulmonary edema? The answer, targeting the core mechanism trap we literally just talked about, is a normal pulmonary capillary wedge pressure. Remember, it's a low-pressure leak.
Next up, question 2. According to the Berlin definition, within how many weeks of a known clinical insult must the onset of ARDS occur? Testing your recall of those diagnostic criteria, the answer is within exactly 1 week. Anything longer than that, and you simply cannot formally diagnose ARDS according to the Berlin guidelines.
Question 3. Let's test your imaging knowledge. What is the classic chest X-ray appearance in established ARDS? Well, you are looking for widespread bilateral diffuse alveolar opacities progressing to white-out lungs. It looks pretty terrifying on an X-ray, totally clouding both lung fields.
Moving on to critical care. Question 4. Which ventilator setting strategy is critical in managing ARDS to prevent volutrauma? To protect those incredibly fragile lungs from barotrauma and volutrauma, the essential strategy is low tidal volume ventilation at less than 6 milliliters per kilogram of ideal body weight.
Halfway through the gauntlet, question 5. A patient with severe ARDS remains profoundly hypoxic despite mechanical ventilation and high PEEP. What physical intervention improves VQ matching? When high PEEP just isn't cutting it, the crucial physical intervention is prone positioning, literally flipping the patient onto their stomach to recruit collapsed alveoli in the posterior lungs. Question 6. Let's go back to the microscopic level. Damage to which specific alveolar cell type results in a deficiency of pulmonary surfactant and subsequent microatelectasis? Recalling our cellular breakdown early on, the loss of surfactant is directly caused by damage to the type 2 pneumocytes.
Question 7. Testing your clinical triggers. What is the single most common clinical trigger for the development of ARDS? Think back to the S at the very beginning of our Spartan mnemonic. The #1 clinical trigger overall is sepsis.
Question 8. Back to the ward. In the management of established ARDS without shock, what is the preferred fluid strategy? Because we have a highly permeable capillary leak flooding the lungs with fluid, the preferred approach is a conservative fluid strategy to minimize any further edema formation. Keep them as dry as safely possible. For our penultimate challenge, question 9. Why does oxygen therapy often fail to correct hypoxaemia in ARDS? This is so vital for understanding the clinical picture. Refractory hypoxaemia occurs due to intrapulmonary shunting across those fluid-filled, collapsed alveoli. Blood is passing through the lungs, sure, but because the alveoli are filled with protein-rich fluid, no gas exchange can happen, regardless of the oxygen concentration you provide. And finally, question 10. A patient presents with acute bilateral pulmonary infiltrates. Which blood biomarker is typically markedly elevated in cardiogenic pulmonary oedema but normal or mildly raised in ARDS? The final answer is B-type natriuretic peptide, or BNP. If it's the heart, the BNP is huge. If it's ARDS, it's normal. That brings us to the end of our gauntlet. How many did you get right? Keep reviewing these key differentiators, because on the ward, ARDS is a relentless race against time and inflammation. When the barrier breaks, will you be ready to spot the great pretender and save the lungs?